So I'm Yahya Al-Bromboli. I'm a lecturer of orthopedic surgery at Zagreb University. I'll be presenting a small talk about growth-friendly surgery in early onset scoliosis. If I can start the presentation. So what are the goals of treatment in early onset scoliosis? First, we need to obtain and maintain deformity correction, achieve adequate spinal growth, allowing lung development, and maintaining a balanced spine. So what are the indications? So if we have a major cup angle more than 45 degrees, if we have a documented progression as alluded by Dr. Nariman, if there is failure of conservative management, there is deterioration of pulmonary function, and we are in the age bracket between 2 and 10 years of age. So what option do we have? We have distraction-based surgeries, compression-based surgeries, and growth-friendly. This is according to the way they correct the spine. So distraction-based surgeries, we have three main categories. One, the traditional growing rods. Two, the vectors, and then the magnetic growing rods. So this is a case example for traditional growing rods. This is a 5-year-old male patient with early onset scoliosis, idiopathic type. And this is intraoperative photo, and this is the growing rod. So we have a proximal foundation. Tenny? No. So we have a distal foundation and a proximal foundation, and there is a rod in between, and it induces a distraction moment, so it corrects the deformity indirectly. So I'll speak a little bit about the surgical technique. After the patient is in the prone position, we mark the distal foundation and proximal foundation under C-arm guided on the skin. Then we do a subperiosteal dissection and pedicle screw insertion and the distal foundation. So you induce fusion down there, and then you repeat the same thing and the proximal foundation. You put your pedicle screws or hooks according to which is ever more feasible. Then then you pass your rod subfascially, which means it's under the fascia, but still over the muscles. You put it under the fascia so that it's not subcutaneous and the patient can feel it. And you don't put it under the muscle, otherwise it will induce friction with the bone, and that will induce autofusion. And then this is the post-operative image with the patient. So you achieve indirect correction of the deformity through the distraction that you do intraoperative first. This is a clinical photo of the patient before and after surgery. Then you go to the lengthening. This type of procedure needs lengthening interval, either every 6 months, 9 months, or 1 year, according to your protocol. So what you do is you need to open a little bit over the distraction bolt, and you hold it with a rod holder, and then you distract. And then you'll have a little bit of movement in change your growing rod to a final fusion so that the spine is corrected and then stable with that. However, this technique has a lot of complication. The reported complication rate is from 30 and delay the initial instrumentation by each year, it will decrease the rate of complication at least 10%. And there is implant-related complication like broken rods, broken screws because of the high moment arm and a lot of stresses over the instrumentation. Besides, there are kids most of the time playing. And there is as well skin-related complication because most of these kids are very thin, sometimes malnourished, and you have to open them up multiple times. So there is a lot of skin complication as well. And proximal junction kyphosis is a problem that happens repeatedly with this type of distraction, because the amount of distraction you induce sometimes will cause a little bit of distal or proximal junction kyphosis. Then I'll speak about the second type of distraction based instrumentation, which is the VEPTER. The VEPTER was mainly indicated for thoracic sufficiency syndrome to increase the space between the ribs. And then its indication shifted to any kind of scoliosis with fused rib. Then some surgeons will even use it in any kind of scoliosis when they don't prefer to put instrumentation in the proximal thoracic area. So this is a case example of a 5-year-old female patient treated successfully with VEPTER, and it is the same thing. You have to distract it every 6 months or 9 months through the distraction bolt as well. We don't have any VEPTER in Egypt so far, but we can use it. There is alternatives for that. For example, hooks. You can use rib hooks. It's the same hooks that you use on the TP. You can use them either all upgoing or in a claw pattern so that you can hold the ribs steadily, and you can then distract from the rods without a problem. And there is the new magnetic controlled rod, which is very similar to the traditional growing rod, but instead of the connector, there is an actuator that you can control it externally with an external controller, so that you induce distraction in an outpatient basis. However, this is not available in Egypt. It's very expensive. It costs about $16,000 each. It needs to change every 2 to 3 years because it gives you about only 4 centimeters of excursion, and the distraction moment of it is weaker than the regular traditional growing rods, so it cannot really correct it stiff curves or multiple congenital anomalies. And there are multiple reports on actuator failure and the failure of distraction with it. So there are a lot of countries that had stopped it again now in the recent couple of years. So since there are a lot of complications to distraction-based surgeries, people are thinking about another option. So the ideal treatment for LN scoliosis will no need to frequent visit to the OR, will harness the normal growth of the spine, maintain coronal and sagittal correction, and minimize the complication. This is the ideal treatment. So people are thinking about different ways of managing. So we have 3 surgeons that thought about different ways. This is Richard McCarthy. He invented the Sheila technique. Genolet invented the modified trolley, and Dr. Ala Azmi from Palestine invented the modification of Sheila using apical control. As a historical background, the Luke trolley itself was described in Mexico in mid-1980s, and it was like sublaminar wires and the rod, and the patient with time will grow out of the rod. It will slide. That is the original Luke trolley. But it's not my time over for sure. With so what is Sheila? Sheila induces apical control and fusion, control the deformity, allowing growth of the spine using the specific Sheila screw, which is a specifically designed screw, which allows the rod to be seated in the screw while allowing sliding motion on the rod in the screw. So McCarthy uses fixed angle screws at the apex to control the apex, induce fusion, and do vertebral body rotation. And Sheila screws at the end of the deformity to control the deformity and allow the growth of the spine over the rod. So, subperiosteal dissection in the apex, putting fixed angle screws, direct vertebral derotation, and then minimally invasive screws put up and down, Sheila screws to allow the spine to grow. This is a case example. This is immediate post-op X-ray, and this is 1 year follow-up. So you can see how much the rods have moved down and up, which means that the spine is growing through the construct. However, there are some complications, especially rod fracture and the extensive metallosis that happens between the screw head and the rod because they are moving all the time. So there is extensive metallosis, and people are speaking about how much it will affect the kids in the future because it's going to be there for a long time. Then I'll get to the modified trolley. The modified trolley induces apical control without fusion. It induces limited fusion at the upper lower foundation and allow the spine to grow through a gliding vehicle. What is the trolley gliding vehicle? It's a gauge the rod, but not firmly, so that it will allow the rod to slide through it. This is a case example. This is a 5 years old with brother Willie. She has a flexible deformity. Immediate post-op. This is regular screws, and his is the gliding vehicle. As you can see, the peak is radiolucent, so it's not apparent in the X-ray. This is immediate post-op clinical photos, and this is 2 years follow-up. As you can see from the immediate post-op, the 2 years follow-up, the rods slided here and slided down here, which means that the spine is growing through the system with the control of the rod. Early results are encouraging, but it's not available to the public yet. It is still under investigation. It's not suitable for stiff curve, and more research is being conducted on it. Dr. Ala Azmi has published his new technique about 2 years ago. He has published 3 consecutive papers about the technique. It's very interesting. So his idea is to do a modified Sheila technique where he will do a convex side apical control so that it will control the most wedged vertebra, and then he will put a proximal foundation and distal foundation with side-to-side dominoes, and he will open one domino on one side and close it on the other side. So the patient will grow out through the open side of the domino. His initial results are very encouraging, and he has published 3 publications about this technique with similar results as growing rods with lesser complication. So I think he has a very good potential of becoming the future. So to summarize, the goals of surgical management in early onset scoliosis: obtaining and maintaining deformity correction, achieving adequate spine growth with lung development and a balance in the spine. Indications of surgery: major cup angle of 45 degrees, document progression in the age bracket. I've spoken about the concept of traditional growing rods, the surgical technique, and high rate of complication. The vector, mainly for TIS and its alternatives. Magnetic growing rod, pros and cons. Then I've spoken a little bit about growth modulation. It uses the natural growth potential of the spine. Sheila and modified trolley are true novel technique with their pros and cons. Apical control is a new modification. Still, we need more research about early onset scoliosis and its management. Thank you.
Thank you, Dr. Yahya. So now we'll open the floor for questions. Are there any questions? So.